Okay, everybody, let's get started. Today's DMEC conference is Dr. Robert Means, who you all know. He's our dean, also a practicing hematologist, and has started a new clinic over in CEB1, help us take care of our heme patients. And in the Grand Rounds format, we've asked all our speakers to talk about what's new in their field in the last year or two to kind of give us an update on what's cutting edge in the different disciplines. And there's Dr. Means's title, so I will defer to him, and we should have some time for questions at the end.
So my assigned topic was hematology update. I'm basically a benign hematologist, although I see, for example, BCR negative myeloproliferative disorders as well. The field of hematology is so broad that you really can't do an update of the field in general without and do justice to it. So what I decided I would do was I would take a clinical problem that is encountered fairly commonly, which is thrombocytosis. And I would talk about how thrombocytosis comes about and the way it relates to the BCR-ABL negative myeloproliferative disorders, which is one of these which is probably the most significant category of diagnoses, again, relating it to a specific case. This is one of the things that's nice about this particular problem is that the BCR-ABL myeloproliferative disorders are an example of where sort of the clinical and kind of the molecular diagnostics of diseases come together to make a unified understanding of diseases. So, disclosures. I'm a member of the American Board of Internal Medicine Hematology Examination Committee, so what you're going to see does not reflect what we talk about at the committee meetings. The presentation, I'm required to state, as if anyone was actually going to do this, that you couldn't take this presentation and package it into a formal advertised board review course. So don't do that. But any event, I have been, in the past couple of years, a consultant to Xenon Pharmaceuticals, which is interested in hepcidin-based therapeutics, which has really nothing to do with the talk, but is here for full disclosure. I'm the editor of a hematology textbook published by Lippincott. And of the figures and tables from other sources that you will see today, I am the author, and therefore able to reproduce them, of all but one. The figure on slide 30, permission was obtained from the copyright holder to use it in this context. So my objectives are to outline the differential diagnosis and approach to thrombocytosis, to identify the BCR-ABL negative myeloproliferative disorders, and to describe the clinical and molecular features, particularly of essential thrombocythemia, and then to talk about, which is really new, the new changes in the prognostic-based approach to essential thrombocythemia management. But first, I'm going to start with the case. This is a patient that I was contacted about when I was at the University of Kentucky. I was sitting in my office one Friday afternoon, got a page from the physician's helpline that one of the extenders in the general internal medicine clinic was on the phone. And what she wanted to talk to me about was a 52-year-old white lady who was a smoker who had presented with left upper extremity arterial thrombosis and atrial fibrillation at an outside hospital. She had been started on anticoagulation and then vanished from follow-up. Sometime later, several months I believe, she developed progressive arterial thrombosis, showed up in the UK emergency room, had an unsuccessful bypass, and wound up having her left hand amputated. She had poor healing, and then she had an amputation to the forearm. When she first showed up in the emergency room with her initial thrombosis, her platelets were 483,000, so above the upper limit of normal, and they gradually and steadily kept rising, and the most recent count that the provider had was 1.1 million. So this is what I was called about on Friday afternoon. So let's talk a little bit about what we're thinking about. But I want first to sort of acknowledge one of my mentors, Dr. Roger Dupre, who was for 30-something years the chief of medicine at the VA in Nashville, and was my attending as a third-year student, my residency application advisor as a fourth year, and then later my service chief when I came back to Vanderbilt as a fellow and then later as an attending. He was, in his day, best known as one of the world's leading experts on the clinical manifestations of histoplasmosis. He was a person of broad education, particularly given to colorful statements at conferences. And one which I particularly remember that he used to like to bring up at M&M conferences and Morning Report and things like that was that sometimes when a case is presented to you, it's helpful to think about what you would title that case if it were a New England Journal CPC. This case would have been entitled, "A Woman with Thrombocytosis and Limb-Threatening Thrombosis." So hold that in the back of your mind. We'll get back to this in a few minutes. So what causes thrombocytosis? What's the classification? So this is from one of my chapters. Basically, there are reactive causes, which are anything that can activate cytokines, infection, inflammation, malignancy. You can see it with iron deficiency. The mechanism of that is not entirely clear. You can see it post-splenectomy, of course, because the spleen kind of acts as a modulator of the blood counts. If you take out your spleen, your blood counts go up. Your white count and your platelet count go up, particularly. You can see it as part of the recovery from thrombocytopenia. You will occasionally see a rebound, although it is typically not sustained, and so it wouldn't have been consistent with what we were seeing with this case. You can see it with any cause of tissue injury. Surgery or burns, for example, are associated with thrombocytosis. Back in the early 80s, a series was done at a hospital in England, which was the first series to actually look at automated blood counts and what were the causes of elevated platelet counts in those folks. And what they found was that the single most common cause of a platelet count greater than 500,000 was the postoperative state. And all these other things followed behind. The next big category are the clonal thrombocytoses, which you can refer to also as primary thrombocythemias. And the most common one is essential thrombocythemia. But the other the most common cause of significant elevated platelets is clonal, is essential thrombocythemia. You're going to have other myeloproliferative disorders, including the polycythemia vera, CML, and myelofibrosis, and rarely, and we'll talk about this just briefly, you can see it with myelodysplastic syndromes. There are also a number of inherited genetic disorders. The thrombopoietin receptor, the thrombopoietin gene itself, and what we're going to talk a fair bit about today, Janus-associated kinase 2. You can have inherited mutations that do that. So what's the distribution of etiologies of thrombocytosis? So when someone shows up in your office and has thrombocytosis, how often are you going to see that, and what does it represent? In this survey that I cite here, 1.6% of patients followed over a 5-year period in a general medical practice had platelets greater than 500,000 at least once. So if you have a big practice, you'll see it. What's the etiology? Most of those platelet counts are reactive, are clearly identifiable as reactive, almost 97%. If you look at genetic disorders associated with it, there are 4 thrombopoietin mutations, 3 thrombopoietin receptor mutations. Occasionally you can run into a hereditary JAK2 mutation, but they're uncommon. Now, it is interesting to note that this might perhaps be more common than we think, since thrombopoietin receptor mutations are actually seen in the heterozygous state in 7% of African Americans, although the platelet count in that population is actually normal. And the rest, basically what's left after the 96.2 8 or so % of these are left are clonal disorders, which is going to be what we're going to mostly focus on. This is an outline of an approach to thrombocytosis. As you decide if the patient has a family history or a lifelong history of thrombocytosis. If so, you think hereditary or the genetic disorders. If you find that the patient has some kind of inflammatory state, then that is likely to be the action, the cause. Otherwise, you would think about testing for BCR-ABL. You would think about testing for JAK2, which we'll talk about, and you would consider doing a bone marrow examination. So if you are BCR-ABL positive, then you have CML, chronic myelogenous leukemia. If you are JAK2 negative, then you have one of the JAK2 negative myeloproliferative disorders. Sometimes people who are sometimes both BCR ABL negative and JAK2 negative may have a mysterious myeloproliferative disorder not otherwise characterized, or they may have a myelodysplastic syndrome. There are also some JAK2 positive myelodysplastic syndromes. So, how do you manage someone reactive thrombocytosis, which is what most of what you're going to see is? Typically, you just manage the underlying disorder and it goes away. If you have a high-risk situation, it's not unreasonable to use aspirin or some other antiplatelet agents. What are high-risk situations? They are extensive. If you have extensive cardiovascular disease and are at increased risk for arterial thrombosis, then it is likely, and you probably ought to be on aspirin anyway. If in the circumstance of people who have underlying liver disease, particularly with portal hypertension, and have a splenectomy, when they develop thrombosis, they have an extremely high incidence of intra-abdominal thrombosis. And that can be reduced once the platelets count starts to get rising up above 700,000, 800,000 by putting them on aspirin transiently. So what about the inherited thrombocytosis? Again, uncommon, but may show up in various circumstances. You suspect it if you have someone who has lifelong and, fortunately, typically asymptomatic thrombocytosis. There's some families that have JAK2 mutations. How does that work? It activates, it's an anti-apoptotic mutation, a gain-of-function mutation that prevents megakaryocyte apoptosis, so more platelets are made. You can have thrombopoietin receptor mutations, which basically lead to more thrombopoietin, which leads to a drive toward increased platelet production. You rarely have complications. They will frequently have a mildly elevated spleen, so they actually could be mistaken for a myeloproliferative disorder. It's autosomal dominant, and there are very few families. Thrombopoietin receptor mutations can either have abnormal thrombopoietin binding, so leading to the receptor just being turned on, or the receptor can be constitutively turned on. This is fairly widespread, but again, typically asymptomatic. Rare to encounter. The clonal thrombocytoses are what you will typically run into other than reactive thrombocytosis. In the myelodysplastic syndromes, there is a well-described disorder of refractory anemia with ringed sideroblasts with marked thrombocytosis. Wintrobe actually first described it back in, I believe, the late 50s. These are people who have a myelodysplastic syndrome that has an extremely good prognosis. They really don't ever evolve to leukemia. Ringed sideroblastic anemias typically have a pretty good prognosis anyway. This actually has a better prognosis than your average sideroblastic anemia. Some of these do have a JAK2 V617F mutation, which is the characteristic myeloproliferative disorder mutation, so it's probably sort of a hybrid state. You can have chronic myelogenous leukemia associated with thrombocytosis. I have been fooled by that in the sort of era when it was harder to get genetic testing on 2 occasions. but it is, it's nowadays with the ready availability of PCR, that really shouldn't happen. So if you have someone that you suspect of a clonal thrombocytosis, your first step would be to check BCR-ABL to rule out a CML presenting with thrombocytosis. Then you get into the other disorders, P. vera, myelofibrosis, and essential thrombocythemia. So, the most important contribution to the understanding of the BCR-ABL negative myeloproliferative disorders was the report of the JAK2 V617F mutation, which is a gain-of-function mutation that that basically leads to increased blood cell, hematopoietic cell production. And exactly what is produced varies from disorder to disorder. If you express this in mice, they get big spleens, they get high counts, they look like they have a myeloproliferative disorder. Now, one of the challenges is the tendency to think of this as like the BCR-ABL mutation in CML, which is pathognomonic, which diagnoses the disease, which entirely controls the pathophysiology. This actually just needs to be thought of as proof of a myeloproliferative disorder. It doesn't necessarily, it's the fact that you have in P. vera myelofibrosis and essential thrombocytosis, any or all, doesn't make a disease diagnosis. It's just a clonal evidence of a myeloproliferative disorder. So polycythemia vera. Polycythemia vera is in many ways sort of the hallmark BCR-ABL negative myeloproliferative disorder. You see it about 1.5 to 2.5 per 100,000. It peaks at age distribution in the 60s. The male to female ratio is slight male predominance to just a little bit dominant. So when we think of polycythemia vera, a lot of us older folks tend to think of the criteria developed by the Polycythemia Vera Study Group, which was done back in the 60s as part of one of the first big national studies of the management and diagnosis of a hematologic disorder. And in order that their studies would be valid, they developed these criteria. And I show this even though the criteria have actually passed and are no longer used, because they're useful of a way of thinking about it. The first criterion was that you had to have an increased red cell mass. Why was this important? Because you had to have you actually had to have an increased red. You actually had to have polycythemia. Why was this important? Because a significant percentage of people who present with a high hematocrit or high hemoglobin do not have polycythemia. They have decreased plasma. This is particularly true in people who are smokers, in people who are overweight, or people who have hypertension. It is referred to as Gaisbach's syndrome in the older literature. It's probably not a real syndrome. It's just like it should be called more like Gaisbach's thing. It's not a pathophysiologic disorder. We don't really understand what causes that. We do find that if we control their blood pressure or get them, which is not that hard, get them to lose weight, which is somewhat harder, or get them to quit smoking, which is frequently impossible, that you can actually correct this. Sometimes it's referred to as smoker's polycythemia, which is a bad term because they don't usually have polycythemia. But in any event, so the first criterion was that they would have polycythemia. The second criterion was that they had good oxygen saturation, and that meant they didn't have the most common non-clonal reason to have polycythemia, which was decreased oxygen production, which leads to increased erythropoietin, which then leads to increased red cells as a way of increasing oxygen delivery. So you didn't have, so this is what you would see, for example, in people who would smoke a lot and develop carboxyhemoglobin, which is a high affinity hemoglobin, holds oxygen in the red cells doesn't get delivered to the tissue, so the body perceives itself as not having enough red cells, makes more. This is what you see in people with severe with hypoxic lung or heart disease. They need more cells to deliver more oxygen. This is what you see in people who live at high altitude, where the oxygen level, ambient oxygen, is low. Another way of looking at the same thing is to say that the serum erythropoietin concentration was not elevated. That is another approach to that. Finally, you needed to have some evidence that you had a myeloproliferative state. And you could have splenomegaly, or you could have a high platelet count, or a high white count, or elevated leukocyte or abnormal leukocyte alkaline phosphatase without a fever infection, or B12 challenges. So this is a helpful way of thinking about it. But in fact, the current criterion are the criteria developed by the World Health Organization, initially published in 2007, but under more or less continuous debate and revision. The World Health Organization criteria are first significant in that they have moved away from using the red cell mass. This is helpful because most nuclear medicine people don't remember how to do red cell masses. And so it's rather challenging to get a red cell mass done, even if one wanted to. But anyway, the criteria uses specific hemoglobin and hematocrit levels, 18.5 or 16.5 in men and women respectively, or a hematocrit, and they use that instead of a specific hematocrit. Now, there's a lot of argument by people, particularly by people who like red cell masses, that that's not necessarily an ideal criterion. A better criterion is probably a hematocrit greater than 60% in men or 58% in women, because if you correlate these findings with like these hemoglobin levels and those hematocrit levels with red cell masses, everyone who has a hematocrit of 60%, for example, if you're a man, has got an elevated red cell mass, or they are in shock from having had a massive blood volume loss. You can occasionally see someone who has a severe capillary leak syndrome who will have a hematocrit around 60 and not have an elevated red cell mass. They will also look like the Michelin Man because they have essentially leaked all of their spare plasma out into the subcutaneous tissue. So now it's based on hemoglobins or other evidence of red cell mass. And you need to have a JAK2 mutation, usually the V617F mutation, or there are other JAK2 mutations on a different exon that are associated with it. And in fact, the laboratory here in the clinic will send off for that and as a reflex. You can order it as a reflex test, that if it's negative for this, that they'll go on and test the other. They also require a bone marrow to make the diagnosis of polycythemia now. You need to have characteristic marrow morphology, which would be a hypercellular marrow without dysplasia, essentially. And you need to, or either a low serum erythropoietin, or you need to show that that bone marrow-derived erythroid colonies grow without added erythropoietin. This is a long-standing, long-known criterion of polycythemia vera, that they were either erythropoietin independent or extremely hypersensitive to erythropoietin, that they could grow without adding erythropoietin. Now, the bottom line is you can't just order that. That's something that has to be done typically by somebody who has a research lab. And so the bottom line is your criteria are marrow and the serum erythropoietin. So if you had a person who has an elevated hematocrit or hemoglobin in the appropriate range, who has a JAK2 mutation, and who has a low serum erythropoietin, you have someone who has polycythemia vera. If you only had one of the first two, then strictly speaking, you would need to do a marrow to diagnose it. So, essential thrombocythemia. Incidence similar to polycythemia vera, a little more prevalent because of it generally is a little more benign course. Now, both of these findings, incidence and prevalence, reflect the old diagnostic criteria, which required a platelet count of 600,000. The current diagnostic criteria, and this is an important point to take away, is basically anything above the upper limit of normal, so 450,000 or up. So this means that the incidence and prevalence must, of course, be higher, since the criteria, the bar to cross to make the diagnosis has become lower. It's associated, like a lot of myeloproliferative disorders, with radon, which is common around here, or gamma irradiation. Farmers, electricians, and hairdressers on epidemiologic studies are at increased risk, and I don't know if the hairdresser's increased risk is from radon or gamma irradiation, but or what else, or just toxic effects of various hair products. But in any event, so those are the occupations listed as increased risk. Now, what are the World Health Organization criteria for essential thrombocytosis? You have to have a sustained platelet count that is above the upper limit of normal. You have to have a bone marrow biopsy that basically shows increased megakaryocytes and no dysplastic changes. You need to not have one of the other disorders, which is what, particularly CML, which is why you need to do the BCR-ABL testing. If you have your bone marrow, will rule out myelodysplastic syndromes, and you need not to have the markedly elevated hematocrit you would characteristically expect in polycythemia vera. Occasionally, I have run into individuals with bad lung disease and a long history of polycythemia who likely developed essential thrombocytosis later in life, but were hard to distinguish from polycythemia vera. Fortunately, the management boiled down to about the same. So you need to have a clonal marker, or if you don't have a clonal marker, and we'll talk some more about some of the other clonal markers, you need to have no evidence for a reactive state. However, if you met all the other criteria and you had a reactive state, and this is kind of a hedge, this is why these are not great criteria, you could say that you had essential thrombocytosis if you just can't explain it otherwise, and you have a bone marrow that is consistent with it. So, myelofibrosis. Myelofibrosis is the third and the least common, and which is good because it's the worst of the BCR-ABL negative myeloproliferative disorders. In prevalence is shown here, and incidence, it's associated with benzene and industrial solvents more so than the others, and with radiation. Men, again, slightly more common to have it than women. This is a disorder essentially arising from abnormal megakaryocytes that produce basically fibroblast growth factor that causes fibrosis of the bone marrow, which gradually replaces normal bone marrow elements. They get marked splenomegaly. They get signs of extramedullary hematopoiesis. They go through a phase at the beginning where their counts are up, and then they go into a phase where their counts go down. They have a fairly high frequency of evolving to a leukemia type picture. So what are your criteria for this? Again, by the World Health Organization, you need to have megakaryocyte proliferation and atypia because, of course, it's arising from abnormal megakaryocytes. You need to not be one of the other myeloproliferative disorders, and you need to have some kind of a clonal marker, and you have to have all of those to make the diagnosis. Minor criterion, of which you need two. You need to have an increased LDH, which is a marker of increased cell turnover. You need to have palpable splenomegaly, not just radiographically present splenomegaly. You need to have leukoerythroblastosis, which is a marker of marrow replacement by something. You can have leukoerythroblastosis, which means you have immature white cells and nucleated red cells floating around in the periphery. That is a marker of normal marrow displacement by something. It could be fibrosis, as in this case. You can see it with solid tumors infiltrating the bone marrow. You can see it if you have a lipomatosis and you have fat infiltrating the bone marrow. You can occasionally see it actually if you have histoplasmosis and you have massive granulomas in the bone marrow. Just as a side point, there is a significant amount of literature that suggests that if you have a patient with a known diagnosis of a solid tumor and leukoerythroblastosis, that indicates with near certainty presence of cancer in the bone marrow. But in any event, and anemia is very common. This is, as I have said, the worst of the BCR-ABL negative myeloproliferative disorders. It is associated with typically pancytopenia, fairly high incidence of evolution to acute leukemia, and basically a marrow failure picture requiring treatment. This is the one where there is an indication for bone marrow transplant if you could do it. Okay, so let me talk a little bit more about essential thrombocythemia, which kind of aligns better with our case here. So, we talked a little bit about the JAK2 V617F mutation. If you're one of the 35 or 65% of patients who have this, you tend to have a higher thrombotic risk than people who don't have it. Which means you behave more like people with polycythemia vera, who have a higher thrombotic risk. It's associated with increased erythrocyte adhesion molecules. So one of the key points to understand is that in thrombosis, in the myeloproliferative disorders with a high platelet count, yes, the platelets contribute to thrombosis, and yes, you're better off if you reduce them, but in fact, the sticky things are actually the erythrocytes, which are present in much greater volume than the platelets. And it is argued, and this is something that continues to argue back and forth, as to whether the amount of abnormal alleles of JAK2 predicts your risk of thrombosis and distinguishes polycythemia vera from essential thrombocythemia. There is a lot of literature which suggests that the two are separated by the allele burden. There's recently been some debate in the last year or two as to how valid that is, but it's probably generally true. So, what is particularly new in this field is the description of the calreticulin mutation. It is found in 25% of essential thrombocytosis, cythemia patient. It occurs almost exclusively in JAK2 negative and also thrombopoietin receptor mutation negative patients. Now, a few months ago, if I had been giving this presentation, actually when I initially wrote the presentation a few months ago, it said occurs exclusively in JAK2 negative people, but there actually are some cases of it occurring in JAK2 positive patients. Exactly what that means, whether that's just an epiphenomenon or or just some kind of a fluke, is not yet clear. But in any event, so this leads to activation of STAT5 signaling, and again, prompts platelet megakaryocytes to survive and produce more platelets. Now, if you are calreticulin positive, you appear to have a lower risk of thrombosis than JAK2 positive patients, and you appear to have a somewhat better survival. You may, and this is some new information that came out, have a slightly higher risk of evolving to a post-myeloproliferative disorder fibrosis, marrow fibrosis. But that's not quite clear at the moment. But in any event, so if in general, if you are calreticulin positive, you have a lower risk of having thrombosis, and it puts you into a better prognostic category. The calreticulin test is available commercially. At the moment, it is not CLIA approved, so you don't get it is not reimbursed. But but likely it will become reimbursed because it is, I think, becoming a standard marker of the disorder. But in general, you would not order it in the evaluation of a patient with thrombocytosis, except in people who are JAK2 V617 or JAK2 mutation negative. The other mutation that shows up from time to time in 3 to 5% of essential thrombocytosis patients is the thrombopoietin receptor, or MIPL, mutation. It's like the other ones, it's a gain-of-function mutation. It leads to constitutive activation of signaling. These patients have higher platelet counts, but they look less like polycythemia vera. They tend to be slightly anemic. They tend certainly to have lower erythroid activity. Their marrows are less cellular. This is, to be honest, a relatively unimportant mutation. Its importance derives from the fact that it was described by an individual who is very prominent in the myeloproliferative disorder field, and because he is so prominent in the field, he is able to make sure that it gets looked at very hard in all the studies. But even so, they still only find it in a relatively small percent. So there are some people referred to as triple negative who don't have any of these mutations. That's about 5 to 10% of essential thrombocytosis. They tend to have a lower hemoglobin hematocrit than the JAK2 positive patients, who again, remember, they look more like polycythemia vera. So you could think of a spectrum of polycythemia vera at one end and essential thrombocytosis, cythemia at the other end, and that JAK2, the degree of expression of JAK2 is what unites them on the spectrum. They do have a higher platelet count and a lower white count than the calreticulin positive patients. So you could think, in that case, of ET here and myelofibrosis over here, and calreticulin expression being the thing that's going to distinguish them, because in that sense, the triple negatives look a little bit more like myelofibrosis. And again, triple negatives appear to have a slightly higher risk of developing myelofibrosis late in their disease. So this is just a summary of the various mutations. There are a number of other mutations that are minor. Most of them are seen in the context of other mutations. This is just here for completeness and has been modified to reflect some recent data. So this is a typical essential thrombocythemia bone marrow. You see that, what do you see mostly? You see megakaryocytes. You see usually on a bone marrow, you would see a megakaryocyte or two in a field at this power. Here you see like a strand of megakaryocytes. You almost never see in a normal bone marrow megakaryocytes in proximity. Here we have clusters of megakaryocytes, or as pathologists who, when they are not thinking of describing things in terms of food, are thinking about romance, refer to as kissing megakaryocytes. So this is a bunch of kissing megakaryocytes. In the background, you see normal-looking, take my word for it, they're normal-looking. All the other cells are normal. What's not normal? There's more of them than there should be. Typically, a bone marrow in an adult is about 40% fat. And this bone marrow has very little fat. That's probably a little fat right there. This may be a area of fat, although I'm not sure if that, probably it is. I'm not sure if that's a nucleus for this. But so typically about 40% of this marrow should look like that, should have like little empty bubbles. So it's hypercellular, increased megakaryocytes, but the megakaryocytes are normal looking. So, what are the features of essential thrombocytosis patients? Again, a little bit more women than men in essential thrombocytosis. They tend to have a relatively normal white count. Some of the differences here reflects the facts that the US and Spain series, those are medians. So it's where 50% is on either side. And the Japanese series are mean results. So a result that is either real high, which some patients with essential thrombocytosis, for example, will have real high white counts, or real low, particularly I think with relation to the hemoglobin, will tend to pull it off a little bit. But in any event, so they have a relatively normal white count, relatively normal hematocrit, and typically, again, platelet counts running up in this range. Palpable splenomegaly is seen in Japan. These were all palpated spleens. They weren't radiologically measured spleens. In the US, they were palpable and radiologically measured, so that's why there's twice as many. In Spain, it was a mix. So about 10% of people, you'll feel a spleen. If you scan for it, you'll see it in about a quarter of people with essential thrombocytosis. Okay, so how do they do? Well, they do pretty well. Median survival is greater than 22 years. Most people with this, are in their 60s when they show up. So, you got a median survival greater than 22 years. That's probably not a huge amount different, as I'm going to show you in a minute, from people who don't have essential thrombocytosis. What do you die of? The biggest single cause of death is other stuff. You die of unrelated disorders. About a quarter of them will die of thrombosis. Now, this series goes back some 20, is several years old and goes back some 20 years before that. So it antedates management, essentially, of essential thrombocytosis. About 14% develop non-hematologic cancers, a little high for as a cause of death, a little high for an age-matched control, but not huge. In these series, again, which goes back into the 80s for collecting patients, about 8% developed leukemia late in life. In many cases, the leukemia that develops in people with essential thrombocytosis is a consequence of having been treated once upon a time with alkylating agents. If you're not treated with alkylating agents, your risk of developing leukemia is very low. And about 4% evolve to a myelofibrosis, which is not the same as the myelofibrosis that you have that's the disorder. It is a post-fibrotic, post-polycythemia or thrombocytosis myelofibrosis. It is sort of an end-stage evolution of the disease. So what's the risk over 15 years of folks developing these problems? 27% of polycythemia vera patients will get a thrombosis over their first 15 years of diagnosis. About 17% of essential thrombocytosis folks. Again, these are accumulated from series that go back kind of into antique management. Leukemia, even in this series, was only 2% in essential thrombocytosis because this series mostly excluded people who had had an alkylating agent. Again, still some risk of evolving to myelofibrosis. Okay, so what's the survival compared to the general population? It's not statistically significantly different. And if you look at it, they're doing pretty well up until, and really not much different, up until you get to around 30-ish years when they just start to drop off. But of course, a certain amount of that would be expected. By that point, you are down to, so, back up for a second here. Oops. So if you look at this, how many folks are we talking about here? Why does it drop so precipitously? Well, there's only 2 people left in the series at that point. So if one of them goes, your survival is going to drop 50% to what it was before the other one. So it's essentially the same compared to general folks. And again, this permission was granted by the copyright holder to use this. So what's the this is one of the newer features of the thing. You should base your treatment of things on how it's going to affect the patient's life. How are you going to correct it? What are the prognostic classification? This is the sort of traditional prognostic classification of essential thrombocytosis. There were two criteria. Were you older than 60, and had you ever had a thrombosis? If you were younger than 60 and you had never had a thrombosis, you were low risk. If you had had either of those or both of those, you were high risk. Obviously, this isn't an ideal prognostic category because somebody, who is entirely healthy and old, a little old, you could go from being low risk on the day before your 59th birthday to your 60th birthday to being high risk the next day when you actually obviously haven't undergone a biological change. A person who has had both thrombosis and is older would seem intuitively to be at higher risk than a person who is just, for example, older, but this system categorizes them the same way. So there is a newer system which was published at the very end of 2012 called the International Prognosis System, Essential Thrombocythemia, Thrombosis. And what it does is it gives points and it includes molecular criteria. So age greater than 60 gets you 1 point. Cardiovascular risk factors, which they define as being diabetic, having hypertension, or being a smoker. This is, by the way, these hold even if these are controlled. So just having the diagnosis of either of these or being a smoker puts you at cardiovascular risk. If you have a history of thrombosis, that puts you at increased risk. If you are JAK2 positive, that puts you at increased risk, and those each get you 2 points. They have not factored in calreticulin, whether that would count as a 0 or whether that would get you a minus. No one can say at this point. There was a recent report, small series, where they looked at how did calreticulin alter this, and what they found that the calreticulin didn't alter this. So if you're low risk, you got 0 or 1 point. What does that mean practically? It means you're a healthy person who's never had any trouble, don't smoke, normal blood pressure, not diabetic, and you're just over 60. Or you're an otherwise healthy person, less than 60, who smokes or is a diabetic or whatever. So that gets you 1 point. If you have either a history of thrombosis or you're JAK2 positive, that'll get you 2 points each. 0, 1, low risk. 0, if you're 2 is intermediate risk, and greater than 3 is high risk. So now we had the category before where things were either no risk or high risk, basically. How did this change that? What this did was obviously the low risk category. Somebody who was low risk under the old category is low risk, may or may not be low risk under this category because they included the JAK2. What it did was it split the old low risk category halfway between this low risk and this intermediate risk. What was the difference? The difference was that roughly half of the old low risk category was JAK2 positive. So half of the old low risk is new low risk, and half of the old low risk is now intermediate risk. What did it do with the high risk category? It split them between these a third, a third, a third. So the people who were high risk just because they were greater than 60, they went to the low risk category. That was about a third. The people who had the history of thrombosis, they tended actually to shift a bit toward the high risk. But anyway, so half of the old low risk split between low risk and intermediate, half of the old high risk, a third of the high risk, old high risk split, a third, a third, a third. So why is this important? Because this guides therapy. Whether you are low risk on the old criteria or low risk on the new criteria, the management would typically be aspirin or some other antiplatelet agent if you prefer it, although aspirin is the best studied, or observation. If you are a young person, or for whatever reason couldn't take aspirin, it might be reasonable to observe you. I'm allergic to aspirin, so if I had this, hopefully at the moment, that's the category I would fit into, I hope. If you're intermediate risk, then this recommendation would be that you have aspirin or another antiplatelet agent. Most people in the US use an 81 milligram baby aspirin. Most people in Europe, where you can get a 100 milligram aspirin tablet, use a 100 milligram aspirin tablet. The conclusion recently presented in posters at least at the hematology meetings last month was that you don't need 325 and anything less than, and a 60 milligram aspirin is not good enough because I guess they have many more different sizes elsewhere. But so 80 or 100, something like that. And high risk, you do cytoreduction. How do you do cytoreduction? Well, first let me talk a little about aspirin's generally safe. Now, what about people who bleed? Some people with essential thrombocytosis don't clot, they bleed. Some people do both because their platelets are abnormal. If it is some people with greater than 1 million platelets have a bleeding history because they have an acquired von Willebrand syndrome. Because their abnormal platelets don't have adequate von Willebrand factor binding. Those are, and some people argue, I don't, but it's not unreasonable, a lot of very eminent people do, say that if you have a platelet count greater than 1 million, you need to check von Willebrand's factor before starting aspirin. Others, and I fall into this category, say just do it if there's a bleeding history. And if you have acquired von Willebrand syndrome, then you get their platelet down under 1 million, and then it goes away. So cytoreduction, how do you do it? The standard, hydroxyurea, well tolerated for a chemotherapeutic agent, relatively inexpensive, not leukemia generating that you would notice. The answer is it's probably not 100% normal, but it has some effects on white counts. The reduction in white count may reduce the risk of thrombosis. Anagrelide just more or less just reduces your platelet count. It produces a little bit of anemia too, but typically not much. It was initially being developed as an antiplatelet agent for cardiovascular disease, and they noticed that everybody's platelets went, kablooey down to the bottom when they put them on it. So it came off the market and then subsequently came in for hydroxyurea failures. Up until a few years ago, there were studies that demonstrated that hydroxyurea was a better first-line drug than anagrelide. People with anagrelide had worse survival and more thrombosis if they were treated with anagrelide first as opposed to hydroxyurea. There was a study done in 2013, published at the very beginning of the year, the anhydrite study, which showed that anagrelide as a first-line agent was not inferior. It was done in a much better way than the original study that showed anagrelide was inferior. So you could, the current thinking is that these are essentially equivalent. Anagrelide's a little more expensive. Interferon, you can use, when it works, it may suppress the clone. No one knows that this actually changes your long-term outcome, but it does suppress expression, for example, of JAK2. Where would you use that? Maybe in the young, maybe in the pregnant with whom you can't use anagrelide or hydroxyurea. In taking interferon is unpleasant. So I have rarely had occasion to give it. Apheresis, where you pherese out the blood cells. You would use it in circumstances like acquired von Willebrand syndrome, and you would use it if you had a case of catastrophic thrombosis in association with essential thrombocythemia or any other myeloproliferative thrombocythemia, which brings us back to our case. So, woman with thrombocytosis and limb-threatening thrombosis. Now, when I got called about this, my first response was, is the patient there with you? I'll come to your clinic and see them now. Of course, they weren't. And so I recommended that they send off erythropoietin, they send off JAK2, they send off iron studies, and send them to see me the next week in my clinic, which naturally, of course, they didn't show up for. But eventually, they got in to see me. So when they got in to see me, when I saw the patient, platelets were 538,000. JAK2 testing was equivocal, which more or less, which basically is translated as negative. It means that there was a small level of JAK2 expression, but not rising to a diagnostic level. So it doesn't count as making the criteria, but I will say that people who have equivocal JAK2 testing do tend to run higher platelet counts in reactive circumstances. She was iron deficient. She also happened to be a heterozygote for methyl tetrahydrofolate reductase, but I think that was probably neither here nor there. Anyway, on her amputation pathology showed that she had osteomyelitis, which may have accounted for her poor wound healing. On iron, her platelets went down to normal. So what was the diagnosis? She had reactive thrombocytosis. The reactive issues were infection, iron deficiency, and tissue injury, both from her poor healing and from her surgery. So just to go back to our objectives, the differential diagnosis and approach to thrombocytosis, reactive versus inherited, which you think of with lifelong asymptomatic, or clonal, which is the 2 or 3% that will be left. What are the BCR-ABL negative myeloproliferative disorders? Polycythemia vera typically has erythrocytosis and thrombocytosis, with erythrocytosis dominant. Essential thrombocythemia, primarily thrombocytosis. Myelofibrosis has splenomegaly and leukoerythroblastosis. What are the clinical and molecular features? We talked a little bit about the clinical features just now. JAK2 in essential thrombocythemia, 65% are JAK2 mutation positive, about a quarter calreticulin positive, some thrombopoietin receptor abnormal, and a small number of triple negatives. What is the prognostic management? If you're low risk, you can observe them, or you can put them on low-dose aspirin. If you're an intermediate risk, you put them on low-dose aspirin. And if you're high risk, you look at cytoreduction. Here's a reference. We have a minute or two a few minutes to take questions. Sorry, I ran a little long. Any questions? Yes. Yes. Well, you know, if you go to the education sessions at ASH, Dr. Teferi will tell you that you should reduce them down to less than 450,000. My own practice, if I could get someone there with minimum toxicity at a near starting dose, that would be nice. I generally follow the old criterion of around 600. If I can get the platelet count below 600,000, I think you're in pretty good shape. Yes. Yeah. Yes. Not that I'm aware of. That is something that needs to be looked into. But as far as I know, it hasn't. As you know, it's relatively new, just described in the last year or so. So I expect that will start emerging. My guess would be that it would not, because it does tend to produce some kind of appears to produce sort of a milder phenotype, and its possible increased fibrosis issues are long-term issues, which may be hard to see in an animal model, particularly a relatively short-lived one, or at least dealt with by impatient scientists, who want to get the paper in before the next meeting. So.
The other question I had was the conversation on allelic burden.
Yes.
And improved monitor for
Yeah.
myelofibrosis.
Yeah.
Accepted?
It is a point that's evolving. A few years ago, I think it was on the verge of getting ready to become something that people were going to recommend as a way of showing that. what has been shown is that changing the allelic burden doesn't seem to change the prognosis or the course. It may be helpful in terms of initial diagnosis, but I don't think it's going to be helpful in terms of monitoring. There is a myeloproliferative network that's been funded, disorders network that's been funded by the NIH. It sends out a lot of mailings and things. Teferi's in it, Spivak from Johns Hopkins, Ron Hoffman, a variety of eminent myeloproliferative disorder folks are leading movers in it. It's kind of like the polycythemia vera study group on steroids and risen from the dead. And they may be able to answer that question in a few years. But that's the sort of thing they're trying to look at. Okay. Any other questions? Thank you.